What is PDMP? We talked about that just a little bit ago.
PDMP stands for Prescription Drug Monitoring Program, and it's essentially a database that would be managed by the state where pharmacies, after filling prescriptions, dump the data into a central repository, and then physicians would have an opportunity to access that data in an effort to determine if perhaps that new patient sitting across from them asking for painkillers has been to see, 5, 6, 7 other doctors in the past 5 days seeking the other same things.
Doctor shopping.
Doctor shopping, in other words, yes.
We heard that we're the only state that doesn't have this in the country. Is that accurate?
That is accurate. Puerto Rico and Guam have this.
So do you support a measure like this?
Very much so, very much so. And we have pushed it several years. And this year, we got it back out of the House again, and it has stalled in the Senate. And it is because, of course, which has already been mentioned tonight, is Dr. Schaaf, he truly doesn't believe in this and feels it's a privacy issue, and so that's where our holdup is at this time.
And we've also had some personal experience. A lot of people come to the table. Do you care to share any of that?
Absolutely. My daughter, she's 28 now. At 17, she was waiting tables at a local restaurant and making hundreds of dollars in tips a week. An excellent student, been in church all of her life, and she cut her thumb opening a bag of okra, and went to the emergency room, had her thumb stitched up, and left with a script of Lorcets. When she finished with the script of Lorcets, she just started buying them at work from different people that she knew, and now we're 11 years into this through many rehabs. And just as they've spoke tonight about heroin, down in the Boot Hill, meth is more prevalent. And so when she couldn't afford the prescription pills anymore because she was taking over 30 a day, she moved on to meth. And that is something that we still struggle with today. It's been a cycle. And so, I spoke on the House floor about this when we were debating the bill, and I told my story because I grew up in drug addiction. My family, my cousin died from prescription pain abuse, pill abuse, and been in legal and illegal drugs throughout my whole life. I was raised very poor. My daughter, however, was not. I kept my children from that. And this spans all social classes. And so it's very important that we start talking about this. And after I spoke on the floor, when I sat down, I had representative after representative come up to me and say, thank you for being so candid. Thank you for talking about this, and tell me their stories. And one gentleman said, Holly, I have never shared this with anyone because I've been so ashamed and embarrassed that this is in my family, and worried about the political repercussions. But that's it. We need to talk about this because this is everywhere, and just as we've heard tonight, our kids are facing this every day, and if we don't start talking about it and not being ashamed of it, but looking for that solution, and this prescription drug monitoring program is a preventative. It's something that can help keep the pills off the street so we don't have as many kids getting addicted before they get into trouble with the police and everything else. This is a preventative measure.
Dr. Miller, we've heard a lot said about the doctor's responsibility. Give us the doctor's perspective on this issue.
So the prescription drug monitoring program is an absolute must. I'll give you an example. So if I send in 10 prescriptions for a very complicated patient to one pharmacy, that pharmacist is going to do a med interaction check to make sure it's like a double wave of safety that I haven't mistakenly given 2 meds of the same class. This is the standard for good medical care. But what if one doctor is sending in a prescription to one pharmacist and another doctor is sending in a prescription to another pharmacist? As of now, the lack of communication between pharmacies is akin to the dawn of email, when organizations would have email like with
internal servers?
Internal servers, right. So you could just email the people within your business or the people within your school, but you certainly couldn't span from one organization to another. That is how backward we are in lacking this drug monitoring program. And as of now, we have to work piecemeal with little pieces of data to try to identify patients who are double dipping or need help for abuse. And And my nurse and I end up turning into like a private investigator trying to figure out how to help our patients because the facts aren't adding up. And if they go to Walgreens, the Walgreens is very good at scanning all the Walgreens to see if that patient has had another narcotic prescription filled at another Walgreens. But they don't know what was filled at CVS or one of the other 200 pharmacies in the region. Sometimes we look at claims data. So for cyber access, we can figure out, well, if someone used their insurance to pay for 2 different narcotic prescriptions from 2 different doctors going to 2 different pharmacies, we can see that data. But that's only if they use their insurance. That's only with particular insurances. We're picking up the phone, calling the pharmacy down the street saying, have you taken care of my patient? Have you prescribed any medicine? Because I'm really scared that the medicine I'm prescribing is going to interact. So the time and resources that are wasted in trying to keep our patients safe is definitely behind the times.
Do guys like you want this?
We would love to have access, absolutely. It would be a good tool for us, but most importantly, it'd be a great tool for physicians.
And that's what I meant. Do you want to see this in place? Not necessarily.
Absolutely. We see it more as a preventative measure. Because if somebody is doctor shopping and they're seeing 4 or 5 doctors getting oxycodone, hydrocodone, whatever it is, and the doctor has a simple 21st century tool, and I loved what you were saying, because we aren't living in the 19th century. This is the 21st century. There is no excuse for us not having a system that doctors can use to improve healthcare. That's it. That is the bottom line. And this will save lives. It will allow physicians to have a private conversation with that individual in the privacy of their office to address Senator Schaaf's concerns.
Yeah, I didn't
about the issue.
I didn't, and so I'll ask you the question. Along the lines of his concerns, do you want to get your hands on something like this?
It could be useful for us, but quite frankly, at DEA, we're not meaning to sound uncaring, we're not interested in the individual drug seeker or drug user. We are much more interested in finding the purveyor, whether it's the street dealer of heroin or that small sliver of physicians who are out there who have simply turned their medical practice into the modern day equivalent of a crack house and selling prescriptions for no medical use for $300 to $500 a pop, as we've seen across the country, as we have seen in Missouri, and just making it a profit-making machine. A tool such as this would help us find those high-volume physicians. But let me be clear, high volume is not necessarily indicative of bad medicine. Oncologists are going to be high-volume prescribers. But what we're looking for are the practitioners who are issuing prescriptions outside the normal course of medical practice, sort of just in a cash for drugs transaction.
We've heard a lot of people saying this problem is getting worse. Where does this rank in terms of the priorities of the DEA?
Well, it's quite high. When we look at the various surveys that are done by University of Michigan and others, we know that there are approximately, 7 million prescription drug abusers as opposed to roughly 400,000 heroin abusers. There's your problem. There are more people who abuse pharmaceutical drugs in the United States, mostly narcotics, than there are abusers of heroin, cocaine, crack, methamphetamine combined.
What do you wish lawmakers were doing? Is there a role that you think, are there tools that you would like to have that you don't?
In Missouri, prescription drug monitoring program, and that is a state system. It doesn't need to be a federal system. We have the tools that we need to do our job, which is to interdict drug traffickers. But we need to see some of these new tools come into effect so that physicians, can play their role and deliver good quality health care and prevent some of these issues from becoming a law enforcement problem.
Is pain management intimidating for young new doctors?
Pain management is not, because in the 1990s there was this burst of advocacy for treating chronic pain. And there was evidence that patients were being undertreated. So in the 1990s, pain became an extra vital sign. So physicians are trained in how to assess pain, how to treat pain. But I think I personally had about 2 hours of training in substance abuse in medical school. I guess I should have gone to veterinary school. So that lack of training is a big problem. And so we either have to readdress medical education, or at our health center, we're working in collaboration with substance abuse counselors right on site, and we're screening most of our patients for substance abuse, and we do an immediate referral. So at least if we don't have the skills to do it, we can collaborate with those who do.
Okay, let's.